Okay, so Willig, when do we start? Willig?
You can share your slide and start your live.
Okay. So welcome everybody to today's seminar. I trust that you're all able to hear me. We today are very fortunate to have the assistance of some of our IT team to just assist us through today. So what we have is the messages that you are able to send through, and we'll be able to see them and answer them, just some housekeeping. And we're ready to start. So I just want to get a go ahead as to whether you are able to see my screen. Yes. So good afternoon. I wish to welcome you all on behalf of the Futureproofing Public Health Initiative team, as well as on behalf of the Division of Health Systems and Public Health within the Department of Global Health at the Faculty of Medicine and Health Sciences, Stellenbosch University. And today we kick off a series of webinars as part of our Futureproof Public Health Initiative. So my name is Professor Renee English, and I'm presenting today and talking on behalf of the broader Futureproofing Public Health Initiative team. So we have 3 speakers lined up today, each who have played and will continue to play important leadership and governance roles in this pandemic, both locally and nationally. And the title of today's webinar is a review of the national and provincial responses to COVID-19 lessons for the future. So I know that you've come to hear them, but we thought we'd just give you a short overview of this initiative, given that it is our inaugural webinar, and just set the scene for how important it is to start thinking about the future when one applies a public health and a global health lens. So in 2019, the World Health Organization put out the 10 biggest threats to global health in 2019. And as we can see from the slide, the global influenza pandemic, fragile and vulnerable settings, Ebola and other high threat pathogens, and very importantly, number 7, weak primary health care, were considered to be amongst the highest ranked threats in global health in 2019. Who would have thought that a few months later, the current reality would be that over 4 million people would be infected by a novel virus, SARS coronavirus 2, causing COVID-19, responsible for over 280 deaths worldwide. So as we thought about this concept of future-proofing public and global health, and these were thoughts that arose in 2019, the questions were, what are the novel, futuristic, yet feasible global health solutions that would consider a range of issues worldwide. We also felt that it couldn't be business as usual for global health, and that there certainly was the need for a call for sorry, I'm just getting messages to say that people are not able to see my screen. I just want to see if that is the case.
Let's share again.
Is my screen visible now? The presentation?
Yes, just share again. We'll put it on the screen.
Okay, will you put it on the screen? Okay, thank you. This is the world of technology in our current reality 22. So just bear with us. I just want to confirm, Felix, are we able to see the screen now?
I'll share it. Just continue.
Okay, thank you very much. So we just need to move down a few slides, please. Thank you. And so the thought was it definitely could not be business as usual for global health. There's also a call for health systems, public health and global health experts to consider the changing times and to plan and implement and conduct research. And then also to consider where the world is going with artificial intelligence, robotics, even epigenetics. And then, of course, very importantly, planetary health and One Health. And another important question was, what is the role of universities in all of this? Next slide. And so we mused and wondered what South Africa would look like in 5, 10, 20 years' time, and how would this shape government's response to health systems, to both public, global, and planetary health issues. Given that the rise of communicable and non-communicable diseases are global wicked problems, and we know that health systems by nature are complex. Thank you. Next slide. And wicked problems require multifaceted solutions. Next slide. So our question was, how should we rethink public and global health to better prepare us to address the complexities of rising epidemics? And that musing in itself was almost prophetic. Who would have thought that we would be facing COVID-19 as a disease that challenges the global community? So our intention is to build a community of practice and to examine global health challenges, to forecast specific challenges, to explore the possibility of novel inter- and transdisciplinary solutions using futuristic lenses, and to ask, if we were to apply these multiple lenses from various perspectives, how can we learn from various disciplines? And what are the opportunities for applying some of these methods and technologies to solve the problems? And COVID-19 has certainly accelerated this and has certainly provided much food for thought, certainly from what Stellenbosch University considers to be the quadruple helix, which is that of community, of civil society, of business, of the universities and of the public sector. And so that is what we wish to interrogate. Next slide. So we have 3 speakers lined up today, and myself and many of our colleagues have had the privilege of working with them in various stages and parts of our careers. Dr. Yogan Pillay, DDG responsible for health programs at the South African National Department of Health, Dr. Keith Cloete, the new head of department at the Western Cape Department of Health, and Dr. Beth Engelbrecht, the previous head of the Department of Western Cape Department of Health. Thank you. Next slide. And we welcome them and look forward to their presentations as they help to think through coronavirus and the future. So our next webinar will take place on the 22nd of May at 4 o'clock. We have a speaker, Professor Mark Lipsitch, who will be speaking about his paper, which he published in the NEJM, entitled Defining the Epidemiology of COVID-19 Studies Needed. And we'll also have Professor Hassan Mohammed, who is part of the team at the Western Cape Department of Health, and with a broader team is leading some of the work around contact tracing and the epidemiology in the Western Cape. And so my final slide, and then over to the speakers to which you actually came to listen today. I would like to just wish all the nursing staff a happy International Nurses Day. We want to express our gratitude and our appreciation to them and particular special appreciation to those working at the front lines during SARS-CoV-2 pandemic. So thank you very much, and over to you, Dr. Yogan Pillay. While we're waiting for the transition, please feel free to type your answers. We've tried to streamline the process, and we'll have a process of answering the questions after each speaker. Thank you. Okay, so we may have a change in lineup, so we're going to ask Dr. Cloete to speak next. I think we just have some challenges getting Dr. Pillay online.
Thank you very much. Can you see my slides?
Yes.
Yes.
Okay. Thank you very much, Renee. I'm quickly going to touch on the status of the epidemic in the Western Cape, then the Western Cape response to the epidemic and lessons learned today to bring it back to your theme. So the status of the epidemic very quickly. Many of you would have seen Professor Slim Abdul Karim's address on the 13th of April, when he spoke about the blue line being imported cases, the red line being imported associated cases, and the green line being community transmission. Now, the graph to the bottom left is what he described at that time as the country experience. The graph to the top left is what we've experienced in the Western Cape. So that is an illustration. So import associated cases, the last one we saw, imported cases, basically beginning of April, we had no more new import cases. Our import associated cases also came to an end in April. But our green line, our local transmission cases, actually started while we had the import and import related cases. I'll come back to what actually happened and why that's different in the Western Cape from other provinces. At this point, it seems that our seeds for community transmission was planted earlier than was planted in other provinces. To the right, we have basically the local transmission is the red, and then imported, and that is our daily tally. To the bottom right, we have, oops, sorry. Oof. Are you still seeing me?
Yes, clear.
Still seeing, okay. So what you see to the bottom is just our experience with cases that have gone up rapidly in the last 10 to 14 days. Our non-ICU admissions, that's our hospital admissions, is going up. Our ICU admissions and our death rate has also gone up. So what happened in our situation? We actually have a very nice analysis now from one of the registrars, is that we had clusters in workplaces that started and seeded community transmission. So you'll see here, these are all the clusters. We have up to about 60 different clusters. There's about 800 cases associated with these clusters. But you'll see that up to 350 of them were in the retail supermarkets. So actually the Western Cape local transmission, you can say, was seeded and planted in your local supermarket, and it was planted from there to establish transmission. We also had now seeing quite clearly law enforcement, so police stations has been one big area. And then pharmaceutical, we had, I'll come back to this later, but we had the GlaxoSmithKline factory in Epping, seeded quite a lot of cases. And then you have an assortment of all kinds of other correctional services, food and beverage, call centers, banking, security, retirement and old age homes, which worries us tremendously. That's one of our risk areas, public transport, etc., etc. And then in health facilities. So you will see up to now, we have 212 healthcare workers positive in the province across private and public. And you can see how that compares to what I just showed you, the retail positivity, the pharmaceutical, and the law enforcement. And what we found was in those clusters, we found quite a few asymptomatic cases. And I'm just giving you a sense of, so the symptomatic versus asymptomatic, because we then tested. And in the pharmaceutical factory, actually, we found more asymptomatic cases than we found symptomatic cases. And then the essential workplace clusters by sub-district. So now you saw the cluster by where it happened. Now we can track the people back to where they live. The people were in those clusters, and you can therefore see a picture. Most of the people that worked in those places actually live in Cloete, followed by Tygerberg, followed by Western, followed by Eastern, and Mitchell's Plain, etc. That resulted in this, and this is what we're seeing now. So this is Tygerberg for the last 14 days, obviously taken on the 2nd of May. We just need to update it a bit. But now you can see very clear pockets in Elsie's River, Ravensmead, in the Belleville South area, and then very worryingly in the Delft area, and the small pocket starting in Belhar, and then in Bishop Lavis is also a little pocket over, sorry, Bishop Lavis is connected to Elsie's River. If you go to Cloete, you'll then see the pockets in Cloete starting to form because of the high seeding of these cases from essential workplaces. If you go to Western, this is almost exclusively in Dunoon, and that's what you're seeing there. That is exclusively seeded to Dunoon. Then just a little bit about deaths. You can see the deaths, and because community transmission has really taken root, our deaths is also increased week on week, and so now we have increased growth of cases, but also our deaths is going up. And again, you can see this in Cape Town, city of Cape Town, and then you can see it across the various sub-districts in the city of Cape Town. The picture of death is something that's very similar, that's been documented everywhere else. The bar to the left is all cases, and you'll see that's the age group for all cases. And you see the big predominance of people in the age group 20 to 39. So 20 to 39 is the big predominance group for all cases. When you go to people that is admitted, you see that group falls away, and to death they fall away. But when you then get to admissions, you see the age group 40 to 59 starts becoming more, but 40 actually all the way up to 80. That's where the age group starts. When you go to ICU, that becomes the predominant people. And when you go to deaths, you see the disproportionate amount of people over the age of 80, 60 to 79, and then the 40 to 59. And then, got too much of that. If you then look at the comorbidities in the disease patients, the predominantly is hypertension, diabetes. That's a predominant two. And the others are much lower compared to that. And what you see in the graphic here is that 94% of all deaths, the person had one or more comorbidity. 65 had two comorbidities. And then there's 24% with 3 comorbidities. And there's 9% with 4 comorbidities. So what's our response been to the epidemic? On the left-hand side is the national strategy. There's the 8 stages. On the right-hand side is what we've adopted in the Western Cape, which is a care continuum approach. And you'll see it's an approximation across this. So we went for community prevention, screening and testing, hotspot identification and response, isolation and quarantine. And then we also went for what is called medical care, the national one. We got for a health platform response, which is from triage and testing into PHC strengthening, acute hospitals, which includes acute hospital beds and critical care, and palliative care, which we've added, which then went to the adverse events, which is your deaths, and then the recovery, which is, so we followed this response very clearly all along. But we're coming to a point now where we say there's principles for revision and the realignment of the strategy. So I can tell you one thing about our strategy. The strategy has changed probably weekly for the last 8 weeks. So our last reflection, and we had Minister Mkhize here, we've had some interactions with the Ministerial Advisory Committee, Yogan and all the others. We now appreciate that in this province, there's a need for a differentiated approach based on the WHO framework of 4 transmission scenarios, and we need to apply it across the province. So actually, if we look at our province, there are districts and sub-districts with no cases. The Central Karoo still had no cases. Then you have some with very few cases that has already been recovered. That's stage 2 WHO. And then you have stage 3, which is some clusters, and we're starting to see that in Paarl and Stellenbosch now. And then you have stage 4, which is established community transmission, which is predominantly the metro. So now we're saying a differentiated approach is required and a nuanced approach for different contexts in the province. We're also saying that the metro and surrounds should be treated as a single geographic entity because it's because of mobility of people and the movement. So what's happening in the metro, we can expect to start happening in all the adjacent municipalities close to the metro. We must also, the strategy must also serve to optimize the use, amongst others, of human resources and testing capacity has singularly become a big challenge for the country in the last week. And a specific focus on high vulnerable people, elderly and comorbidities, as I showed from the deaths. And I think the big lesson for us is now to continue to adapt our strategy with emerging evidence. But the big lesson, which I'll come back to, which is we've been very much evidence-led. So let the evidence tell us where our strategy should go, rather than the other way around. And in real time, adapting as you go. So the lessons learned to date, I'll just make a few statements. Message number 1, epidemic is growing fast in the Western Cape. Sounds obvious, but that is the message that we have, and it's borne out by the evidence. We have more than 50% of total cases in the country. There's significant mortality in hospitals. And it seems to us that I think the consensus now is that our epidemic was just seeded earlier, and it's all, in all likelihood, the rest of the country is going to follow. It is just that we were first, and others will probably have a similar pattern going forward. The second question, which we keep on reminding ourselves out of our early data, is people will recover. And most people will recover. So we need to understand, accept that it is like flu, a self-limiting infection. 90% will recover through self-management supported by PHC. 10% will require hospital admission, and less than 2% will pass on. But that's been the experience, and we need to remind ourselves that that's what we're dealing with at big scale. The third thing is this differential approach is needed. There's different rates of transmission. Public messaging to influence behavior is critical. So social distancing, hand washing, and masks. And big thing that we've learned, which we need to move on to very quickly, is strengthening agency amongst individual and communities. The behavioral change that's required is probably the big thing that sits with us now. So in hindsight, we could say, well, 8 weeks ago, we should have spoken to behavioral scientists as at an outset. 8 weeks later, we're saying we need to change behavior, but we've seen a very fast establishing of community transmission. Message 4, we need to prepare the health platform for increased cases. We are doing modeling, and we are putting our scenarios with ESSA and Masha and the modeling group, and we are planning for a peak towards the end of June. So we prepare our primary care system. We need to prepare additional acute beds and critical care beds. We need to work with the private sector, and we need to strengthen our palliative care system. Number 5, localized plans are needed. It's important that there is localized plans for in geographic areas and individual facilities. That should include service provision for people with COVID and non-COVID. There's a lot of things that we need to track in terms of chronic disease of lifestyle, HIV and TB, immunizations, maternity care, mental health, as well as plans for staff and occupational health. Now, this has been our biggest challenge to date, and it's surfacing now as secondary bushfires on our own platform. And the big thing is staff safety is our key priority. So the safety of our staff is now our top priority. We've developed a range of occupational health and policies and stuff. There's some malalignment because we produce so many different documents. We've invested in securing PPE. Training is happening, but how do we empower local leadership to support frontline staff to actually be the ones, frontline managers that can hold the fears of frontline staff? And the big thing is that our staff members are scared and anxious. We are starting to recognize the fears and anxiety. We currently have 217 healthcare workers across public and public that's tested positive. There's been 3 deaths today. So this is a huge thing for us that we are adapting to. And then I guess the question that you asked me to reflect on, I'll be very honest. When I thought about this, Renee, the future, to think of the future and to think of where you sit in COVID, The future is extremely far in the future. COVID has made the future the next 2 weeks. That is the reality of what we face, the next 8 weeks. So it's kind of made us into this kind of immediacy and right in front of us. But local and rapid learning is important. So learning as things emerge is probably the biggest lesson for us. And learning is important to learn that we should locally and rapidly learn as we actually do things, as we are embedded. We've never been embedded in anything more than we're embedded in COVID. We are 100% embedded in it. It's kind of in the COVID moment. And probably there's a lesson in there as well. Sharing of experiences and lessons amongst different settings should inform policy review, which is what we're trying to do. And then the last one is relationships matter. So strengthening relationship is critical during this time, and support for each other within the department as well as partners and communities, and opportunities like this to share with you broadly, but opportunities to open ourselves to learn more. Thank you very much.
Thank you very much, Keith, for that fantastic presentation. So we have a number of questions that were posed during your presentation. The first is from Charles Visonga, who says, given that workplace bushfires in the Western Cape, or given these workplace bushfires in the Western Cape, are we safe to start reopening schools in the province in June 2020?
Thank you very much for that question. We, and Beth will probably speak about it. Beth's presentation is about other sectors. So I won't answer too much, but I'll just say that Beth and myself are talking, we are talking to the head of education. And from a logistics point of view, it is very difficult for us as the health sector to see schools going back.
Okay, thank you very much. We look forward to Beth's presentation. I think the team here are still just have indicated to me that there seems to be a problem getting both Beth and Yogan online. So please just look out for your emails, Beth and Yogan, so that we can just link you in. We have another question here from Prof. Catherine Chu. She says the global case fatality rate is 6 to 7%. So why do we think we will only have a case fatality rate of 2%?
Okay, so we have worked on 1,000 deaths per million, and that is what we originally worked in. Our current case, our death rate for current known cases is at 1.8. So if you take our current deaths and the current known cases, we're running at 1.8 at this point in time. As the cases increase, our ability to test the cases increases. So what has happened in other countries, as the cases increase, then the number of known cases that is known to people, the deaths go up. So crude death rate is actually not a very accurate figure, because all you do is the more cases you have, the less you can test. And therefore you have less known cases and more deaths, and therefore your crude mortality rate goes up. So with that in mind, we are working more on death rate per population, and that is what our modelling is looking at, and we're putting that together with ASA and with the measure and the modelling group to see what is a realistic picture from death rate per population rather than death rate as a crude death rate of cases.
Thank you. There was a point of clarification as well. When you refer to 350, was it clusters or cases?
Sorry, no. The 350 in the retail store, that's the cases that's associated with retail stores. I can go back to that slide. But the clusters is over 60 or different clusters. But that slide, this one, it's 350 cases associated. So these on the left is the number of cases that's in. So it's 350 cases that's associated with retail stores. Now that is something like 25, 30 different retail outlets, but it's 350 cases. The next one is about just short of 150 cases across police stations, and there's also many police stations. But the pharmaceutical one is literally only two factories. That's the 100 cases, or one factory actually.
Thank you. And another question that we have is has to do with TB testing rates. So the question is, we know that TB testing has dropped by 50%, but how has HIV testing or ART initiation been affected? So this was the question posed as it is.
Yeah, so I mean, I think one of the things we would like to do in tracking with the team is to get on top of those things. As I said to you, COVID is all consuming, it's taking all our energies. I looked at the reports yesterday, and we obviously have a reduction in all of that, but it's really getting the real data, looking at it more critically. That's one of the things I've asked the team. And we probably in the next 2 or 3 weeks, we'll look at all of those from the perspective of reaching up what has happened for the first 4 months of the year. So because we're 8 weeks into this, and we just have to remind ourselves sometimes we're 8 weeks into this. You know, the impact will be what is our 12-week impact. So when we get to the end of this current 4 weeks, it's the first quarter of 3 months. What does that quarter look like to comparable quarters of the previous year? But that is an important issue to track, as much as chronic disease medicines being delivered, as much as all other measures that we have to track. Yeah.
Thank you, Keith. Another question is, what is the average turnaround time for the lab results? And before you answer that, I just want to encourage people to please log your questions onto the chat, and we'll ensure that Dr. Cloete is able to answer them. Thanks, Keith.
Yeah, so the current average turnaround time in the labs is probably, we got an analysis and we have somebody looking at it, Samir Bray is looking at it, and he's probably going to give us something later today and tomorrow. But over the weekend, we had as high as 14,000 tests in backlog sitting in the 3 NHLS labs in this province. So we've had waiting times for up to 7 days, 5-7 days. And the labs are trying to prioritize the test for health workers. They're trying to prioritize persons under investigation in your hospitals awaiting admission. But it's just a huge backlog. They worked away 3,000 tests yesterday, but been waiting to see what the impact is. So currently, if you take a test in the public sector in the Western Cape, you probably will wait 5 to 7 days for your result.
So linked to the question around turnaround time, there's been much debate around why the Western Cape's cases are higher than the rest of the country. And I mean, you spoke a little bit to that in terms of catching up. But what does it mean in terms of the testing strategy that the Western Cape adopted compared to the other provinces? And what does that mean going forward, given the broader picture around the supply chain for testing, the actual labs, how they function, the turnaround time, etc.?
There's quite an interesting thing when you look back, and when if I go through that strategy, actually it made quite sense to me when Professor Abdul Karim, in one of the meetings where he was, and he made this point to me. I'll just illustrate it by virtue of one of the slides, which is this slide. He actually made the point where the country was going to surveillance and active case finding, which was actually stage 4. That is where the community screening and testing was conceptualized, because it was conceptualized as if we have a lag and a very low take up in community transmission. So the window was do community screening and testing, because we have a lag in community transmission, actively find cases, isolate them, and then delay it further. That was the logic for community screening and testing. In hindsight, that strategy was implemented in all 8 provinces and in this province at the time where our province actually started seeing hotspots. So what happened is our testing morphed into stage 5, where everybody else in the country was doing stage 4 testing, if you understand from that graphic to the left. So I must say, when he said that, it kind of made a lot of sense, because basically means we started following hotspots, which I just illustrated to you. If our testing strategy was active case finding, but linked to clusters and linked to hotspots, which in a sense has not been as pronounced in other provinces. So that explains the difference in testing, and it explains, in a sense, the difference in, let's call it, positivity rates for the testing rate. That there's a lot of talk in the media and whatever that the Western Cape positivity rate is much higher compared to other provinces. What that has done, and as other provinces have been doing, testing as well, is to scale up in testing to maintain a level of testing as cases increases. The capacity has not kept up with it. And so we're currently sitting with a real conundrum in the country where we need more testing. The capacity is unconstrained. So now we have to prioritize testing and use testing selectively, while like in places like ours, you could probably still have benefit by continuing testing and following little clusters and bushfires for isolation and quarantine. So it is a challenge. You know, I can't speak to NHLS. I've been part of meetings with Yogan and everybody, but there are obviously all the efforts are made to get the reagents and the kits for Gene Expert and all these other things, but at the time that we're competing with all other countries and specifically the US.
Thanks, Keith. Another question that was asked pertained to sorry, I'm just finding that question again. Your strategy. So the question was, what is the strategy for the old age homes?
Yeah. So at this point in time, we regard old age homes and the institutions as a high risk institution. So the strategy basically is one of limiting the entry of people into the old age home. So the number of people that potentially can bring community acquired COVID into the old age home. So that is a very rigid screening. And then on top of it, very enhanced PPE. So we're working with our DSD colleagues to actually get to that point. There's vulnerability on both of that. There's vulnerability on picking up the rigor of people coming into the old age homes, people that might have a community acquired, and putting the elderly people at risk. And the issue of PPE is a big challenge. So, but both of those, we are trying to streamline and to really put a big focus on that. That is in old age homes and in retirement villages. We mustn't forget that there's a big proportion of older people and vulnerable people with comorbidities that's not in old age homes and retirement homes, that's actually living in communities. So we also have a focus on households where we know there's elder people and people with comorbidities at risk. So we also want to turn our, let's call it our community teams, into teams that locate and identify households at risk with older people and people with comorbidities, to put special precautions in place to protect people there. And maybe do our selective screening and testing around the protection of elderly from that perspective.
Thank you very much. I just want to check in with the IT team. Have we managed to resolve some of our problems?
Yes, Prof.
So,
Right. Doctor, yeah, is in.
Thank you very much. So as we prepare, Keith, if you wouldn't mind indulging me, I just have two more questions to ask you. The one is pertains to stock outs, and interestingly, it's about stock outs for non-COVID or HIV or tuberculosis drugs, and questions about that.
I reminded you.
Phenobarbital and so questions around that and what the solutions are to possible stockouts for other drugs, and then also the introduction of Gene Expert platform and thoughts around that. Thank you.
Yeah, because I mean, that's a general challenge. Even before we started with COVID, there's a global challenge, and it was a result out of that for pharmaceuticals, that the active ingredients predominantly was produced in China and in India. China went into lockdown and didn't produce active ingredients. And India became inwardly focused and decided they're not going to export. They're first going to look after their own needs before they export. So the issue of drug stockouts had a lead time that started towards November, December already. So we were working against a backdrop of international shortage of active ingredients, and that's before COVID. So we've been doing everything we possibly could, but again, it's a global issue, and it's really competing with scarce resource across the globe. Then I think your second part, I didn't quite remember that.
It was just around Gene Expert.
Yeah, I mean, the whole point about Gene Expert, the issue is getting access to the kits. And the machines are here. It's getting access to the kits. Gene Expert is produced by a company that serves the US. The US has basically said it wants all the kits, and NHLS is competing with that big demand to get basically scraps off the table, if I can paraphrase what Kenny Chetty would say.
Thanks very much. There are a few more questions, and I hope we can ask some of them at the end. And I think that the last comment speaks volumes about a futuristic approach to global health systems and what that means. So over to you, Yogan. I did introduce you, Dr. Pillay, and it's a real pleasure to have you here today. Thank you very much.
Thank you very much, Professor English. I hope you can hear me now.
Yes, we can, and we can see your presentation.
Oh, great. Thanks very much, and apologies for disrupting your flow of presentations, but I don't think it matters. I think we can always circle back to the Western Cape. So I'm going to present what's happening nationally, what's being done nationally, and I will move the slides if I can. So just to present globally where we are with respect to the global situation, I think this slide shows quite clearly where South Africa, well, certainly where SADC lies in the global situation, and you can see SADC and the African region are following the global picture, but we are quite far behind in terms of the number of positive cases, as well as the number of fatalities. So, in terms of the epidemic, global epidemic, it might be some solace. We should take some solace in us going last, so we can learn from others. Where are we with respect to SADC? You can see that we are really leading the pack when it comes to SADC. South Africa has the highest total number of confirmed cases as well as mortality, 78% of total cases and 68% of fatalities relative to all of the SADC countries. If you look at the South African case, I think the numbers here have been fairly well described and repeated often. Safe to say that we've got over 10,000 cases reported. And as of the 11th, on the 11th, which was yesterday, we had 637 cases, and we have a cumulative number of 206 cases with a case fatality rate of 1.9%. This next slide.
Yogan, sorry to interrupt. I've received a message to say there's no sound. People can't hear. I just want to double check if that's the case.
Oh, I don't know.
No, not from you, from the IT group.
Oh.
I can hear.
Are we good? Thank you very much. Thank you. All right, go ahead, Yogan.
So, no, sorry. So in this slide, we tried to do a timeline in terms of when the first case was reported, what happened between the first case and the first death. And you can see there's a fairly long break between the first case and the first reported death. The 21-day lockdown, when we started community screening, and you can see how the cumulative cases rose over this period through to last week. And you can see a fairly steep rise when we started community screening. Now, what we don't know is, of course, what the impact of the lockdown has been and what would have happened had we not had the lockdown. We have some modeling data on that, which we can return to later. This slide basically shows the number of new cases per week from the beginning of the epidemic, and you can see that on the extreme right-hand side of the slide, that the stacks are quite large, and you can see then that the epidemic has certainly started to roar from about the 22nd, the week of the 22nd of April. led largely, as Keith has already said, by the Western Cape and to a smaller extent by the Eastern Cape. Again, this is just another slide that shows how each of the provinces' contribution has been week by week through to the 11th of May. And you can see again that the Western Cape and the Eastern Cape were the major contributors to the increase in the cases. If you look at the next slide, it's really the same kind of picture as we've shown in the previous slide, again from the first case on the 5th of March. In terms of deaths, first reported death was around the 27th, 28th of March. And again, you can see the fairly sharp rise from about the week of the 16th of April to date, again, largely led by the large number of cases in the Western Cape. And I think one of the things we have to ask is, why has Gauteng and KZN, which we were expecting to lead the peak, not risen as sharply as the Western Cape? So while we ask why the Western Cape has risen so sharply, we should also ask and try to answer why the other two provinces at least have not. This is the total number of deaths. If you look at the laboratory testing, this has been an area of much concern, largely because we aren't testing as much as many people think we should be. We are now testing around 14,000 or reporting on about 14,000 tests done on the 11th yesterday, broken down by 6,400 in the private sector and about just over 8,000 in the public sector. And of the screening, total screenings, about 4,800 were done from clinics and hospitals, contributed the 9,800 as passive case finding. And again, the lower part of that slide shows the number of tests done per province and the total positivity rate. And again, you can see that the positivity rate in the Western Cape at 7.8% is significantly higher than everyone else. And the only other province that comes close is the Eastern Cape at 4.1. So one has to ask, fairly critical questions about our testing strategy. Are we testing in the right places? Are we testing the right people? Especially given the limitations in the testing capacity, largely the number of kits we have. And again, this just shows the tests done in the private and the public sectors. And you can see that there are certain days, at least more recently, where the public sector is doing more tests than the private sector, though initially the private sector was leading, and that was when we had imported cases. And now that we have community transmission, you can see much of that is being done by the NHLS. Now, this is a slide that's causing us a fair amount of concern. And these are the number of tests that you need to perform to get one positive case. And you can see that it's very highly variable by province, while the overall is 33 tests to get one positive at the national, that's the national average. You can see the range is from 13 in the Western Cape to a very high 163 in Mpumalanga. So clearly we need to figure out in those provinces that have very low levels of transmission, what the testing strategy should be relative to the Western Cape and the Eastern Cape, at least, and perhaps KZN and Gauteng. In terms of community screening, this data unfortunately is skewed by the mass screening that was done early on. We will start looking at the screening, community screening done and together with the referrals that we've been doing more recently, which is much more targeted. But this includes all the mass screening, and you can see that Limpopo showed a very high number of people screened, largely because they were doing mass screening. So the quality of the screening would be something that we would have to ask questions about. In terms of contact tracing, we're doing rather well with the contacts we've been able to identify, and this basically reflects, this slide reflects the number of people we've been able to identify and contact. You will see that there is a gap in the Eastern Cape and in the Western Cape in the data that we have, and maybe Keith and Beth can comment on that later on. And this is a slide on the hospitalizations, number of cases, recoveries, and deaths, which the Minister reports daily, and you can see that the Western Cape has a large number of cases, and together with Gauteng has a fairly significant number of admissions, followed by the Eastern Cape and KZN, with the other provinces having very, very few admissions and very few deaths. This is hospitalized data in terms of high care, ICU, people on ventilation and oxygen. As we get into the peak of the epidemic, these issues will become more and more important. We have done some modeling to show when we will run out of beds as well as ICU beds, and that's something that should worry us a fair bit. We've been looking, therefore, at the private sector beds that we might be able to contract as the public sector. This shows quarantine. There's a lot of issues around quarantine guidelines, who should be quarantined, etc. I won't say anything more about it. Safe to say that we have a large number of beds and sites to quarantine people should that be needed. The cost is not cheap. It's about 1,000 rands a person per night on average. This is just showing you the activated beds against the planned beds by province. The next few slides basically tries to do what Keith has been doing as well in the Western Cape, but these slides are showing the Eastern Cape and shows basically the clusters around which the transmission happened and where did it move. And you can see that the funerals in the Eastern Cape, or at least in Nelson Mandela Bay, together with retail shops, saloons, house parties, and resulted in a fair amount of transmission and a fair number of cases, the 384 in Nelson Mandela Bay. And the same kind of picture is seen in Chris Hani, where they had 113 positive cases, again, funerals being a major conduit for transmission. And finally, Buffalo City, which is a slightly different picture. There, the prisons were the node for transmission, but sparked by a warder who attended a funeral in another district. So the movement of people from one district to another and congregate settings such as prisons, shopping centers, etc., are clearly what has been driving the epidemic in the Eastern Cape. So we need to figure out, how transmission is happening province by province, district by district, and hence, as Keith said, we need a highly differentiated strategy in both understanding the epidemic by district and what the interventions should be. What we have now subsequently done is try to figure out where the hotspots are. So what this map suggests is that if you take the active cases, and the active cases are the cumulative cases, but subtracted from that would be the recoveries and the deaths, to look at, and this is an average for a week, because of the variability day on day, we thought we will take the average over a week. And this map represents the average of active cases between the 2nd of May and the 8th of May by district. And we put in a fairly arbitrary legend. So if you have, and this is per 100,000 population, so if you have 0 or below 0.5 cases per 100,000, you're in the dark green. And you can see that much of the rural provinces and the rural districts have very low levels of positivity or number of cases, active cases during that week. And if you look then at the green, slightly higher, and the reds have 10 or more active cases per 100,000 population. And what we want to use this picture to do, limited as it is by the data and the metrics we use, is to look at how this changes week on week, to both predict or at least follow how transmission is happening and where we need to maximize our resources. So we think that the test kits then and the testing rates in the red and the orange districts should be much higher than in the green. So we'll use it also to look at how to move resources around. We are doing more work to see if we can get a much more robust way of depicting in a very dynamic way, the way the transmission is happening and where we need to put our resources in and where we need to prevent infections from happening. Because clearly, you know, wherever we've had few cases, we need to ensure that they remain in that space, meaning that they should continue having a small number of cases. So then in conclusion, we can see the rate of increase in cases and mortality is highly variable by province, and I clustered them around 3 groups of provinces, the Free State, Limpopo, Northern Cape, and Northwest as one cluster, then Gauteng and KZN, and then Eastern Cape and the Western Cape. This will also speak to the movement of people between provinces, as well as within provinces. So, and we think that the rate of increase is also going to be variable by district, and hence we did the district map, which I just showed. Key will be to test, isolate, treat, do the contact tracing, and where possible quarantine. Clearly that has to be our mainstay of our strategy. But we need to also, and I think this is something that Keith mentioned previously, is also focus on prevention. Clearly we have a challenge with testing capacity. That means we will have to determine who to prioritize and where to send our test kits. And finally, that we must focus on the clusters of infections where there's rapid transmission and close them down. So this has, major implications for this, the issue that I think is in the media right now and that we are all seized with, and that is the whole issue of the lockdown. Do we continue locking down the country, whether we move from 4 to 3 to 2 to 1, or do we start thinking in a much more differentiated way about locking in districts, sub-districts, wards? And I think that's really where we're going. Given the variability in the way the transmission is happening, at least currently, and the impact of the national lockdown on the economy. I'll stop there, Renee. Thank you very much.
Thank you very much for that very informative and fascinating presentation. I think many of the viewers will really appreciate the granularity of that presentation. Before we continue, I just wanted to know if, Keith, you wanted to address, if you can remember the question that Yogan posed around the gap in the data.
Yeah,
Renee, can I just ask for permission to step out to do another little thing and then I'll return?
Yes, you may. You may.
Thanks.
Thank you. Thanks, Keith.
Yeah, I can just said very easily. Now Yogan's not here.
We'll pass it on to him.
Yeah, the gap in contact tracing data is an artifact. And it is when the first imported cases came. For the first 2 or 3 imported cases, there was some erroneous thought that the entire flight had to be contacted. And the flight manifests. And it was only after the 3rd week or second week, I think, where everybody was saying, look, if you're a known case on a flight, then it's everybody within 3 meters of you, like, behind you, the seat behind you, the seat in front of you, and the seat to the right or whatever it is, or to the left. So after that, it got refined. But that first 2 weeks, we had cases on flights where the entire flight manifest was supposed to be contacted. We never contacted the entire flight, but the system that was set up still records the old flight manifests as a shortage in contact tracing. So our contact tracing, actually, in real terms, for community transmission, has been above 90% for our context.
Thanks very much, Keith, for that answer. I'm not sure if Yogan is back yet.
Yeah, I'm back. Sorry.
Okay, wonderful. Okay, I don't know if you got the message, the response from Dr. Cloete.
Yes.
About it being okay, fantastic. Okay, wonderful. So yet another question. It just relates a little bit to what you spoke about around easing the restrictions, and the question is, what are the communication strategies that will be employed? Because at the end of the day, and Dr. Cloete alluded to this as well, and I know that certainly in the Western Cape from the Premier's announcement yesterday that there is an increased attempt at engaging with communities, messaging, and behavior change. So at a national level, what is the strategy? Because we know that infections are inevitable, but it's very much dependent as well on personal inter and intrapersonal behavior.
No, we fully agree. We fully agree. I mean, the Minister has been at pains to urge all of us to focus on two broad things. One is the health sector response, which we have been spending a lot of time on, and secondly, to focus on social mobilization and what is called behavior change. The Minister is, as I think most people know, the Minister has a ministerial advisory committee of professionals, health professionals. He's in the process of creating a ministerial advisory committee focusing on social and behavior change, including social mobilization. We have already been in discussion with the civil society front, which has been formed of about 10 networks of civil society organizations under NEDLAC, and they have a nerve center at the national level and at provincial levels, where they have 5 pillars of action as civil society linked to the government strategy. And the 5 pillars are human rights, social mobilization, advocacy, communication, and what they've called contact tracing. So we are linking with them to try and figure out how best to take the national response into communities where they are well placed, because most of these NGOs have local presence as well, not just a national presence, to look at how best to do that. And I think the point that Keith made about us leading from the top and not doing enough about getting people to lead from communities is right, and I think we've learnt our lesson, and we need to now correct that in order to ensure that people have a full understanding of why certain decisions are taken, and to the extent that we can, to ensure that also that decision making is as transparent as possible, or at least as far as we can, to communicate them in ways that people can appreciate, so that people can then align their personal and their social behaviors with what needs to be done to contain transmission. Because I think what's quite clear now is that any further lockdowns may not work very well in terms of either lowering the peak or shifting the peak out. Thanks.
Thanks very much for that. Just an update. So it appears that we are having quite a bit of trouble connecting Dr. Engelbrecht. We will continue as we still have some time left. There are still some questions to answer. So I hope you will indulge me, both Doctors Cloete and Pillay. One of the questions here, which I'm not sure is, which is more for you, Keith, is if retail is the largest category cluster and we have geographic clusters in largely poorer areas, are you able to break down some of the geographical locations of the retail stores with where they are located and some of these broader areas? I think what this person is trying to ask is there a link other than clusters in terms of transmission?
Yeah, I thought I tried to illustrate that in the presentation. If it wasn't clear enough, then I apologize, I probably went too quickly. The illustration that I tried to do is to say that out of all of those cases that were at the clusters, the next slide was a slide of where everybody lived that was in the clusters. And there was a very clear distinction that most people that worked across those clusters lived in Khayelitsha, followed by people living in Tygerberg, followed by people living in Western. So there's a very clear link between the people that contracted COVID as part of the cluster and their geographic location, which then I linked onto the geographic hotspots, which is where I showed the maps with the big color codes, because that's where the people live, and that was the seeds for the big geographic spread that we see now. So there's a very clear correlation between that.
Okay, thanks for clarifying that. I just want to encourage the participants, if there are any further questions, to keep sending them through, please. I think as we move towards conclusion of the session, because it appears that we will not be able to join Dr. Engelbrecht. It appears there's some network issues there. May I ask from both of you, in the future, Keith, and you put it really beautifully in saying that the future is in the next 2 to 8 weeks, and there's rapid learning, etc. But and I have seen that the Minister of Health has alluded to the fact that, you know, that let's put NHI on hold. But what have the lessons been, given that NHI is the goal that this country hopes to realize through the financing mechanism of national health insurance? And what are your reflections on that, and what are the lessons learned, and what will you take forward with you into the future once we see the back of this pandemic? And we believe that we will see the back of this pandemic eventually, even if we are not able to institute a complete elimination. So I just thought maybe your thoughts on that.
Me first or Yogan first?
You can go first. Thanks, okay. Keith.
I genuinely believe when we set out to do this, Renee, our management team and our frontline workers, or everybody, well, the middle management, we use the planning for that platform. The reason why we use that platform response, the care continuum, is we were saying, let's use this opportunity to strengthen our platform and strengthen our system. So for us, just one example, when we had to make a decision that social distancing is a key imperative for curbing the spread as a healthcare system, we had to make a decision within a space of 2 weeks to decongest primary care facilities that at any given time would have had up to 800 people congested between 4 walls in the waiting room on an average day if you go on the Cape Flats. So one of the things that we had to say to ourselves, look, we've been trying to decongest our health facilities for the last 15 years. We have to do it in the next 2 weeks. So what I still remember the day, and it was actually within 5 days of a couple of brainstorming ideas, and people said, okay, we're going to tell people not to come to the health facility for their chronic medication because we will deliver to their homes. And in 4 days, system was worked out, which was presented by Sadiq to the Minister Kizi on Saturday. And it's kind of, we do it as like a footnote, but it's actually quite a huge achievement. And then in 4 days, we achieved that Uber, a combination of Uber and a community health worker, delivered medicine packages to 20,000 people in 1 day, 4 days later, to their homes, into their hands. Now that's like real fast tracking innovation and re-scripting a system. There's no way that we can, after COVID, go back to the system where we don't actually entrench that practice. And actually, we worked out the price. It was marginally 29 cents per packet. That's actually the margin that we paid on getting that delivered to each person's home via Uber. And there's some refinements that you can do. So this is one example of chronic medicine being delivered to somebody's house, that if it wasn't for COVID, we wouldn't have done it in that way. So one of the things I think the future holds is that we are re-scripting, we are repurposing, we are re-engineering the healthcare system as we speak. And I don't think it's gonna ever return to the pre-COVID configuration. So for me, I'm kind of probably a little bit more philosophical, is that we are creating the future through what COVID is actually presenting to us in the way that we respond on a day-to-day basis. If I have to take myself 4 years down the line, let's take a year down the line. Our relationship with the private sector, very interesting one. We're about to actually have some configuration with them with rates and what we're going to do and how we actually do. But last week we agreed that we're going to have guidelines that will apply to the management of patients, irrespective of whether they're in private or public. Now again, it's also a little footnote, but 4 months ago, it would have been very difficult to dream of that within 4 months, we would actually sign off guidelines between the college and our department, and everybody, all specialists in this province will say we will use the same clinical guidelines and algorithm and decision making, whether you're in the private or the public sector. So I'm just using 2 examples of things that gives us an opportunity to re-script the system towards universal health coverage. And the third one is the one that you mentioned, Rene, because this thing that the testing is not available and we're waiting 5 days and we're not quite sure how we're going to do quarantine and isolation. Actually, what the teams have said now, without that tool, what are you going to do when you go into communities? Actually, what people are saying, we need to have a conversation about community-oriented primary care. We have to have a conversation about social distancing, behavior change, all of those things. And we're going to do it now with local communities. We're going to tap into the CAN movement. We're going to tap into things. What are innovative models? And all of a sudden, there's an energy to actually go into the hotspots, but actually truly engage people in the local areas, into small local pockets, which will stand us in good stead in terms of setting the footprint for community-oriented primary care, as the footprint for the UHC system. So I must say I'm philosophical, but I believe this is an opportunity and we're rewriting the future in the present. Thanks.
Thank you very much, Keith. We'll hear from Yogan and then we'll take it from there. Are you still with us, Yogan? Are you perhaps on mute?
I'm unmuting. Yeah, I'm unmuting. So is the question the legacy of the potential legacy of COVID?
Yes, in a way, and the impact that it has for NHI. What does it mean for us as we plan for NHI?
So Keith's right, and just to kind of pick up from where Keith was, that it does provide us with a platform of thinking about how we partner with the private sector with respect to whether it's beds or human resources. But I think most certainly, and I might have missed, and Keith might have touched on this, it certainly showed us the fault lines on inequity in our country. And I think, you know, if we don't learn a lesson from COVID, which we should have learned more than 40, 50 years ago, about inequity and its impact on humanity, and at least South Africans, I'm not sure that we will ever learn it. So one of the key things that must come out of this, our response to COVID and the impact of COVID, is how do we, in society as a whole, reduce levels of inequity, and what is it that we need to do to create a whole different society? So I think we must create a different health system. There's no question about that. We need to also create a different social system, but we also need to create a new economic system, because we can't keep perpetuating the inequities of the past, which we've done, unfortunately, including the fact that we have not been able to redraw apartheid spatial boundaries. So, you know, it gives us a chance to rethink the kind of society we want to live in, our children, grandchildren will live in 10, 20 years from now. And this is an opportunity I think we must accept. My concern, though, is that I don't think we are applying ourselves to the bigger project. You know, I was on a webinar last week where the conversation was about whether or not a ban on alcohol or a ban on alcohol sales was a good thing. Now, in and of itself, that's an important question to ask. But the key question is, you know, instead of asking it in a siloed way, you know, what kind of health system we need, what kind of primary healthcare system we need, or what kind of response we need to alcohol use in the country, we need to ask the bigger question and locate then the specifics that we are we are asking within that broader question that we need to answer. So for me, the opportunity this presents goes beyond what we do with the health system. It goes to the heart of what kind of society we want to create and what kind of people we want to be, frankly, in 10, 15 years from now. And I think that's the opportunity that COVID gives us. I must say, though, unlike Keith, I am less optimistic about whether or not we can do it, because I was very optimistic in the early 90s. But we can see that by a few areas of progress, we still have large numbers of people living in poverty in the country. Thank you.
Thanks very much. And I'm very aware of the fact that we have 15 minutes left, but I'm also extremely pleased that we do have Dr. Engelbrecht with us. So on that note, and we'll reflect on your comments as we wrap up, but I would like to hand over to Dr. Engelbrecht and welcome her and thank her for her tenacity in just pressing through so that she can be part of this webinar. Thank you.
Thank you, Renee. Thanks also for the IT college. It was now a marathon, 30 minutes trying to get me connected as a presenter. So I trust you've got the presentation because my office sent it to you. So so thanks for that. Okay, so what you asked me to focus on, Renee, and I'm sorry that I've missed now a lot of what Yogan has presented. I just caught the last sentence, and it seems like there's a lot of correlation in the thinking. You asked me to look at opportunities and challenges, the role of health versus the other sectors, and then what do we stand to learn. So I've really made a very brief summary of just a few thoughts. So we can go to the next slide. And that is actually just a reality check to say that, and I'm sure this is evident, that the health sector is the sector at the brunt of the epidemic, and we have to provide, and as a sector, we can say that we're the brunt of the epidemic, but actually our communities are at the brunt of this epidemic. But as a sector, we are at the brunt, but I must say our main concern is our communities, especially with the economic downturn of the extended lockdown. So clearly there's a massive impact. So we then, as a central health sector, then have to provide evidence and support and leadership across the whole of government and the whole of society in the response to the epidemic. There is a need for a coherent and interconnected response plan, focusing on containment and mitigation. So clearly, we have to focus on both, but obviously the biggest investment will be on the containment side to be able that we contain. And I think your topic of future-proofing is what are we learning in both these big phases of containment and mitigation in this epidemic. So we, and you've discussed that also with Keith's implementation, just go back one slide. The number 5 is a critical point, and I think you also started off with that, Renee, is the issue of complexity. The interdependency with other sectors and the community, combined with quite significant political pressure, add to the complexity of what we have to deal with. This is a true VUCA, which is volatility, uncertainty, complexity, and ambiguity experience is calling for system and organizational resilience. And then just to say that there's a myriad of literature, and just staying on top of that is already a challenge. And the strategy and leadership requirements to COVID provide opportunities. The next slide. This is the same slide that Keith has presented, but I would like to make a few comments here. We've got 13 provincial departments in the Department of Health, and our position is that every department has a responsibility to at least one sector. And the role that we play is to support the departments to take responsibility for their sectors. So, for example, the Department of Agriculture has to take responsibility for the whole agriculture sector, farmers, farm workers, the unions, whatever go, they have to take that responsibility, and we give support. The department, if you can see here, the particular sectors affected, and Keith also spoke about retail. So we're working with the Department of Economic Development and Tourism, and they are the conduit. They facilitate all conversations. I've been meeting with hardware stores, with shops, Pick and Pay, ShopRite, Checkers, all of this. So we work through that department to be able then to reach the particular sectors that they have a responsibility towards. It releases the burden on health, and it also empowers them to build relationships with those sectors in a time of a lot of need and anxiety. The other one you can see, the law enforcement, that is a national department, but our Department of Community Safety is our conduit to that. Just at 12 o'clock today, I met with SAPS and the SAPS leadership because of the large number of people infected in that environment. So we work through our sister departments to reach the sectors and to be able to strengthen linkages and networks of linkages across the whole province, so that health can look inwardly and work for itself and sort itself out, whilst we then work with the other sectors and work with communities on the ground. So I think that's a particular one. The other one that you see on this list is correctional services, which is also a national department. And again, through our Department of Community Safety, we reached out to correctional services to say that how can we support you? We know you're in a difficult situation, etc. So that is the main aspect that we work, the methodology by which we work. And you can see these sectors, as Keith has said, are largely those who are active in the stage 5 lockdown. And we know that when stage 4 lockdown and the others open, it's going to be a particular aspect. So in preparation for that, I've been engaging with the Department of Education to say that how can we work with you? And earlier today, we also met with the Higher Education Committee of all 4 universities to say that how can we work and how can we support them in terms of preparation for the students that will return. So on this slide, as Keith has indicated, just between 200 and 250 is the health workers. So the next slide then show the health workers, public and private. And particularly here, the private sector is a very critical sector for us to work with. And again, what we found, we just last week had a learning collaborative with them to talk about healthcare workers who are infected, and how do we learn from each other, because the health workers are so critically and vulnerable in this period. And it was quite interesting that in the public sector, we are very open and transparent. We presented case studies. We talked about that, what can we do better? We had occupational health specialists in IPC specialists, and also people management specialists and labor. So we were quite openly talking, and we could get a sense that in the private sector, due to the nature of their business, it does appear that from a culture perspective, there is some room for them to work with us in developing that type of openness and transparency. So we will have follow-up sessions in that regard again. But given your topic, Renee, this is a particular sector. Obviously, we are contracting with them for acute beds and critical care beds and palliative care beds. And that relationship is a critical one for us to get right, because we know that is an investment for us going forward. The next slide just talks about the fact that health needs to provide leadership in this VUCA environment. We need to show the type of vision that's required, and ultimately, where do we want to take the health sector, and how do we use this shock to our system to be able to strengthen us to be better and go forward. Kind of that is the visionary approach that we do follow. The issue of understanding of courage and agility, and talking of courage, what Keith has stepped in as a new HOD on the 1st of May, after the 1st of April, has been a significant challenge and the whole department in terms of the massive change from one HOD to another, going from relatively stability to a massive shock to the system, and how the whole top team under Keith's leadership is taking courage to hold everything together, because we need to show the hope for our staff members. The next slide, if it shows, I'll be very grateful. If it doesn't, it does, great. Okay, so this is a slide that we've been, it shows the efforts that we've done up till now to look at social determinants for health. And there we say we need a whole of society approach that is citizen-centric. So the people in the center is kind of the stories, the people's lives whom we'd want to change the stories. And you can see the various departments, all of them then focus in a municipal area as a geographic area where everything comes together because it focuses on society. You can see some of the departments colored in blue with blue circles. So they are your frontline type of departments which have a more direct interface with the community. So they play a kind of a frontline role. These in green public works and settlements are more kind of in support. Your agriculture and community safety are more oversight bodies. And then your departments with red circles are the departments that are actually more in governance roles, like economic development, environmental affairs, local government, etc. So we fostered this approach and this relationship in 4 learning sites in the province to see how can we learn to be able to change people's lives and pull the whole of government and whole of society together. So I'm putting this in as it's relevant for where we wish to go as a government. The next slide then talks about what we've learned in this COVID epidemic and the type of roles that actually started to emerge. Firstly is to be a trusted partner to various sectors. They look up to us and we are very fortunate in this province to have public health specialists, and they are absolutely amazing and so responsive. Saturday afternoon, within half an hour, I arranged a meeting and they were there. It's just amazing. So, and that and also the fact that we've got a lot of information that we can empower people to know what's going on in their sector or in their community. Then providing evidence, support and strategy guidance. And this is the role that we are playing with our provincial cabinet to give advice. And we pull on all the expertise and the data to help us interpret that and also link with our national colleagues in that space. We are a convener of improvement. We are a convener of learning. We are a facilitator of agency. And for people to take agency and responsibility for their role. One example, I think there was one of the questions was, what about old age homes? What about other places of social distress or social risk? And we are kind of putting not pressure necessarily, but helping the Department of Social Development to step into that role of being the responsible partner and department for all those type of services, and we provide them with support. So we help them with agency, and obviously agency in the general public is an area that we wish to invest in more and get that right, and we are looking at various mechanisms. One of our learnings have been that given, well, I can speak only from a Western Cape situation, is that our communities are quite risk tolerant, if I can call it like that. They've been exposed to water shortages, power outages, food shortages, job losses, HIV/AIDS, TB, violence, all of these, and they just have to take risks and be courageous all the time. So COVID is just another risk, and how do we find a way by which we change that, by which we empower and make it attractive to take agency. I don't have to go to the other side. I'm very aware of the time. We're a partnership builder, and this is the one from a culture perspective, is that our aim is to say that we can't do this alone. We are a universal recipient of things that go wrong in our society, and if we want to look at social determinants of health, we need to play a partnership builder role, a boundary spanner role, a network holder, and also a catalyst for change. And these are clearly, one can talk a lot more about these various roles that we play. But I think to the point that Yogan ended off with is that how can health do play a stewardship role for a healthy society, or for a society that actually changes? And how can we use the current epidemic to help us in that journey? The next slide. I've got only 3 left. The lessons learned. We've learned that relationships in good times are powerful in bad times. And the converse is also where there were just fracture lines in the past. Those fracture lines show very vividly. And we saw that within a department, but also across departments where there were relationships. Yet what we also found is that silos, people, you know, units or departments or sectors or individuals who kind of did not necessarily feed into the fact of interdependence, suddenly those silos fall away because we are all dependent, we are united with one, if I can call it the enemy. And that shock to the total system is actually uniting people, and we can get that interdependence is recognized. Information sharing and evidence build confidence and trust, and strategic partners emerge. We've got now a much stronger partnership with our unions because we are open, we're giving them information, they feel empowered to be able to support their members, and they are also holding us accountable. The same with our universities, the municipalities, other departments, etc. And then the last lesson, which is something that we've always been very strong on, is always to look at opportunity in anything that goes wrong. And clearly here also don't let the good crisis go wasted, to rather focus on what we can learn. Okay, the last 2 slides. The next slide is a slide that has been kind of the approach of the capabilities for universal health coverage, which has now been adopted by the National Health Council Technical Committee, which we then say, what are the capabilities that we are learning in this epidemic, and how will those capabilities stand us in good stead when we move on our journey towards universal health coverage? And the first one is service delivery capability. At the moment, the biggest focus is on strengthening primary health care, strengthening our community-based services, strengthening our interfaces into people's homes. And how do we get that right? And how do we redefine what services do? This is what UHC is, the capability that UHC is asking of us. And we are now forced much faster to do that, both strategy number 1 and 2 in that first service delivery capability. And obviously there's also now the hospitals, etc., but also particularly the relationship with the private hospital sector for them. And we've got now the same clinical guidelines for palliative care, for critical care, for emergency care, and for acute care. All 4 those clinical guidelines are now adopted across public and private, so that they can then change the way that we render services across those sectors. From a governance capability, I don't have to talk more about that. Leadership and governance is the fundamental issue, and the stewardship role that health plays at the national level, at the provincial level, is critical for us to really strengthen and make the best of this learning opportunity to strengthen our governance capability. Then people and systems capability, it talks about how do we engage with our people, how do we make sure that our staff feel much more valued, and how do we strengthen all our systems, information systems, infrastructure systems. The delivery of testing and triage centers has been significantly faster, and it just shows what can be done. Different procurement strategies. Why can't we do that in all days? And then the last one here is your learning capability. So we are investing a lot. As I've mentioned earlier, we've had one learning collaborative focusing on the healthcare worker across public and private. The next learning collaborative will be on how to reach vulnerable and poor communities. What are the best strategies and mechanisms to interface and bring agency there, given the realities and our context. So those are the critical capabilities that universal health coverage will ask of us. And how do we take what is happening now to launch us much faster to where we want to be? Then the last slide. What we stand to learn, it's kind of just a confirmation, is that the stewardship role for health, we are learning a lot about that, and we still have to learn a lot more. Now that we are at the center, now that health is in every policy of every sector, how can we make that a standing matter, that health matters, and that health can be the issue that all departments unite around? The centrality of leadership and governance, dispersed leadership. We are expecting our services in the front line to take very difficult decisions. And what authority do we provide them, and what support? Boundary spanning leadership is just how do we have convening capabilities, etc. The requirements for systems resilience for whole of government, whole of society, and for the health sector on its own. I don't want to have to go in detail, but what are the skill sets? How do we organize ourselves differently going forward? What are the partnerships, and are we comfortable with uncertainty and emergence? And are we tapping into those capabilities? And ultimately, are we becoming the learning organization we wished all along for ourselves? Thank you very much.
Thank you very much, Dr. Engelbrecht, for a fantastic presentation. And very few of us are able to actually have and have insight to the things that you were talking about, but it's so important to speak about the whole of society approach. So I'm very aware that we are over time, and thank you very much to those of you who were able to stay a few minutes later. I just want to note that there are some questions that we were not able to answer, but I would like to just indicate that we hope to answer those questions and put them on our website, and we'll make those details available to the participants. And then in 30 seconds, if I may just put you, Keith and Beth, on the spot for last minute, it appears that Yogan had to leave, is, this higher educational institutions are about learning and teaching and researching. It's a very different function to the practice of public health, which you've been embedded in. But in a moment like this, it's about more than just public health. It's about a range of skills and capabilities. In 30 seconds, what is your word to higher education institutions?
Can I go?
Yes, you may.
I would say it's my challenge to higher education institutions would be, how do you make your what you offer experiential, and how do you introduce learning by doing, by embedding people into real life learning situations and networks, and how do they uncover or discover what we're learning, what we're doing now? Because we are now in the last 8 weeks, as Beth said, we've become experts at learning by doing and doing by learning. Thanks.
Thank you. Thanks, Keith. Beth.
Renee, I think the critical thing is that it can't be business as usual. We can't keep on with curriculums and with learning methodologies that is the same as in the past. There must be a change towards COVID, what we are learning from this. The fact that society needs economic return. It's going to take years to come back. We've got people under tremendous pressure. So every department in any university has got a role to play to bring society to a point where it is flourishing and we are caring the best for the vulnerable. If a vibrant child is our unifying factor, what is it that a vibrant child needs from each and every department in any university to be able to teach and train and make sure that whatever we do, we can actually, all of us collectively, deliver on a better society? Thanks.
Thank you very much. And it's on that note, I know the big focus is whole of society, and it's on that note that I wish to conclude the webinar. Thank everyone for participating, and also just indicate that we will try to answer the unanswered questions through our website. Thank you very much. Enjoy your afternoon and your evening.
Thank you. Bye-bye.
Bye-bye.